I announce curse stripping is the winner. I am biased. Now it's my pleasure to introduce Janna Bentley, the president of Canadian Society of Phlebology. Janna is the president of the Canadian conference that is running just now in Montreal. So she can't be with us today, and
Hello, my name.
Play the video for her.
My name is Dr. Janna Bentley, and I'm the current president of the Canadian Society of Phlebology. And I'm honored to be a part of this meeting, even though it's remote, because my own Congress is happening right now in Montreal. But perhaps I'll see you in the questions. I'm not sure if we'll be able to pull that off, but thank you, Dr. Fakhri, and your team. So venous disease in children. Does it happen? Do children get varicose veins? And is it always associated with the syndrome? Are there risk factors we can look for? What are the risks of progression? What are the predictors of future venous problems? When should we treat it? How should we treat it? Is it different than in adults? And what are the clinical signs? So the incidence in general in school-age population of venous insufficiency is 0.2 to 2.9%. Genetically, it does seem to have a bit of a dominant pattern. If both parents are affected, there's a 90% chance of kids developing varicose veins. One parent in female children, 62% chance, and in the male children, 25% if they have one parent affected. Neither parent, 20% chance. A lot of the work I've seen has been done in Germany and in the Netherlands. East German study of 403 children aged 8 to 18 had a 15% incidence of lower extremity venous abnormalities, and this was Schultz and Ehrenberg in 1989. Bochum did a really good study. He evaluated school children in Germany 3 times, starting in 1992, and used Doppler and photoplethysmography in 518 children and divided them into 3 groups, 10 to 12 years old, 14 to 16 years old, and 18 to 20 years old. In the 10 to 20-year-old group, none of them had varices of the trunk veins or tributaries. 2.5% had venous reflux in the SSV and the GSV. In the 14 to 16-year-old group, 1.7% had trunk varices, 0.8% had varices of tributary veins, and 12.3% had saphenous reflux. In the 18 to 20-year-old group, 3.3% had trunk varices, 5% had tributary varices, and 19.8% had saphenous reflux. The prevalence of reticular varices increased from 10.7% at the first exam up to 35.3% by the 3rd exam. And the overall development of varicose veins over a 4-year period was 2% and a 4% progression to incompetent communicating veins. The girls had more reticular veins and telangiectasia. The boys had more trunk varices, branch varices, and incompetent perforators. Photoplethysmography showed shorter filling times in children. So varicose veins in kids, we think of things like Krippel-Ternani, Parkes-Weber. We think of the inheritance and predisposition. Mason and Vish et al., they did a retrospective study of 38 kids in the Netherlands. And they were looking at 18 years and younger. They had 49 exams done and an average of 1.3 times per child. And all exams were done standing with color flow duplex ultrasound imaging. And again, the reflux was measured as greater than 0.5 seconds in superficial veins and greater than 1 second in deep veins after calf compression or Valsalva. 28% of these patients were girls, 10 were boys, and an average age of 14.5 years. Of the 49 exams, 17 were seen for suspected DVT and 21 were seen for varicose-related complaints. So the main presentation in these kids was pain, 50% of the time. 4 children of these 38 were prepubertal, like 6 to 8 years old. And of those, 3 were suspected to have a DVT and 1 had a known factor V Leiden. The remaining 1 was examined for varicose veins. 40% of these 38 kids had abnormal duplex exams. Varicose veins and venous malformations were found in 12 of the 38 patients, and 57% of those were investigated for varicose veins. Reticular varicosities were seen in 20% of those diagnosed with varicose veins on duplex. What Mason and Vish found as far as the distribution of varicose veins goes is that the 12 with varicose veins had trunk incompetence in 9, perforator insufficiency in 1, and an AV malformation in 1. And that one person also had trunk incompetence. No abnormalities were seen in 6 to 8-year-old or prepubertal children, and 11 of those 38 children with varicose veins, 6 were males and 5 were females. So the sign and symptom summary for varicose veins in kids in this study, pain was the main symptom. Edema, it was not commonly seen in kids, and the presence of reticular veins was important, and concurrent DVT in the lower limb or pelvis. I was looking into this because it's interesting. Dr. Johann Rog, I met him when I was in Krakow at the UIP a few years ago, and he was actually studying kids with varicose veins. And he was studying the kids of parents who have varicose veins. And he found quite a high incidence, asymptomatic though. And he was trying to strengthen the valves with hyaluronic acid and injecting that into the valves. So it'll be interesting to see what comes of that. I couldn't find any studies to show. Treatment of varicose veins in children, do we treat them or not? Do they have symptoms? Is it just aesthetics? And do we use the same methods as adults? So there are some case reports out there. There's a 10-year-old boy with a traumatic perforator incompetence that was successfully treated with EVLT. And then in Poland, they've done some studies with teenagers and showed great results. None of them had Klippel Trenaunay. There was 100% closure at 24 months. They did. Hello, my name is Dr. Janna Bentley, and I'm the current president of the Canadian Society of Phlebology. And I'm honored to be a part of this meeting, even though it's remote, because my own Congress is happening right now in Montreal. But perhaps I'll see you in the questions. I'm not sure if we'll be able to pull that off.
Very
but
nice
thank you,
talk.
Dr. Fakhri, and your team.
I think we have time for one question. Yeah, I have time for one question for each speaker. Yes. Professor Moshat. سؤال لمين يا باشا؟ لا مش online. But you can send him. You can text him.
Okay, so if you wanted me to declare the question for him, it's just about
Yes.
it's his hypothesis for the HIFO with this high risk of failure, around 25% is a failure rate. This is too much high for a thermal ablation by the end, around 50, 85 degree, which is very similar to the radio frequency or the EVLA. So what's his hypothesis for the failure? Is it the non-touch of the intima? And one more thing is that why he is not using the HIFO for the tributaries instead of doing the sclerotherapy of lobectomy as long as it is effective in the saphenous vein.
Thank you, Professor Mossad. Please, Suhail, text the question and send it directly to Francesco, and I'll let you know by tomorrow. Other questions? Yes, please.
It's for Dr. Mervat. Yes, thank you very much. Why we are insisting still on the estrogen-based contraceptives, although the progesterone-based is seems to us as it's very effective and safe for the patient. So if we are concerned about safety and efficacy, we got to start with the progesterone. So why we are still insisting on doing a combined contraceptive, although the estrogen has been proved effectively that is harmful for the patient, for the development of varicoses and development of VTE later on?
Thank you for the question. It's easy for us to speak as doctors, as specialty doctors, and as healthcare workers. But I will give you an example from my country. In Romania, the combined oral hormone contraceptives, usually you can get them over the counter and they're cheap. And female patients know about them and they just simply go to the pharmacy and ask, and they receive, because they prefer it this way than to go pay for a consultation and receive a proper guide, from a doctor. So that's why in our country, for example, they are still widely used. Of course, for us, for doctors, we know we prescribe what we have to prescribe, but a very small percentage of females come to us. So I think it's very important for general practitioners to be in terms with this information because they mainly reach those kind of doctors. Gynecologists, of course, because they reach mainly at birth and at special problems. They don't go regularly to consultations just for the purpose of receiving contraceptive guidelines.
Thank you very much. This is a very neat explanation, and it's the patient willing. This is the patient willing to go through this. Thank you very much. It's a very neat explanation. Thank you.
Thank you, Mervat. Thank you. You have another question?
Actually, it's not a question, it's a comment, because in the term of your explanation of the cryo stripping, you just claim that the risk of recurrence should be less because there is no vein anymore. I may argue for that because in the usual way of surgical stripping, we have a lot of recurrences, although the vein is not there anymore. Why is that? Because of the new vasculature. You did a trauma, a surgical trauma, which induces more endothelial function activity. This trauma induces an overwhelming catastrophe of chemical agents that induces more endothelial proliferation, which is the commonest cause of recurrence. That's why in surgical stripping, as well as in the cryostripping, you will have a recurrences that is away from the site of original varicosis. You will have it in another site, in the back of the thigh, in the medial aspect of the thigh, in the lower part of the leg. And surgical trauma, as well as the cryostripping, there is still a high risk of recurrence because of the new vasculature. So how can you explain absence of the vein because of stripping would reduce the recurrence?
So as I told you in my presentation, the recurrences are new varicosities. Of course, are new varicose veins. It's not the same vein. Like in the thermal ablation, which the recurrency appear usually on the same vein, which is recanalized. So in order to avoid recurrency, for example, in cryostripping, like in classic surgery, we use compression stocking to after the surgery. If necessary, we can perform sclerotherapy on the new varicosities, phlebotomy medication, and so on.
Thank you. Thank you, sir.
Thanks, Sergio.
Please, Dr. Musad, يعني, what is the guarantee that the recurrence at the groin due to new vascularization, not due to missed tributary or unnamed tributary? What is the evidence based?
If this is the point that you have a recurrence because you missed the tributary, let's say that as we have been taught in the early medical life, you got to ligate all of the tributaries at the termination of the saphenous vein, like the inferior epigastric and like that. And you don't do that with the radio frequency or the EVLA or whatever. Despite that, you don't have a recurrence because of these tributaries. You have a recurrence with the thermal ablation because of the recanalization of the main trunk of the vein. So you have the recurrence at the same site of the previous or the original veins. While in surgery, the surgical trauma itself is the cause of the new vasculature, but you may have a missed vein like the anterior accessory. You may have this missed. In thermal ablation, and Dr. Ayman may come in my side because he has given a fantastic talk about that thermal ablation will reduce the incidence of recurrence through the anterior accessory. That happened, right?
But I think with the flush subfrontal disconnection, there is no room for recurrence.
Let's say that you have a patient with anterior saphenous vein, and you do stripping. Is that vein is gone? It is still there. You overlooked it. But when you do a thermal ablation,
the same matter with thermal ablation.
I mean, the same patient, you have the same thermal ablation, EVLA or whatever. There is a transmitted heat at the site of entry of that vein, and that vein is not connected to a refluxing vein anymore. So you don't have a recurrence, you have a residual vein. And
Thank
as I
you.
And
use
so there is difference between
yes,
recurrence and
it's not
residual
a
veins.
recurrence, there is a residual vein. And as I
Another point.
yeah, and I am always saying that varicose vein is not a disease of recurrence. It is either persistence of some of the missed veins. So it is in a dynamic situation. It's a chronic disease that needs over supervising the patient and ablating any veins that may appear later in it. So you keep coming and seeing the patient and doing whatever he has in his later life.
Thank you, guys. You are both are right.
Dr. Mahmoud.
Okay, I'll give just a word. You are both right. New vascularization is one of the causes of the recurrence. New vascularization is present even in thermal ablation. There's no one only factor for recurrence. There are 4 or 5 factors. Let us admire both factors. But I agree, varicose vein could be a treatable disease. Please, Dr. Omar.
A very quick 1 minute comment is whenever you publish a paper about varicose vein, you must put the definition of recurrence, how you define recurrence. Most of the paper accepted is recurrence of the disease in the treated area or untreated area. And we know from literature that any surgical maneuver around a vein trigger angiogenesis, and this will trigger recurrence, new recurrence by new vascularization. And we also know that we can miss a lot of collateral around the groin, which are very small, by time they still grow. So by definition, both your argument are defined as recurrence. You can have recurrence by missed collateral, which is due to either the surgical technique or the collateral was very small at the time. Or angiogenesis is well proven. Whenever you put a knife around the vein, you are triggering a reaction which will cause angiogenesis. So both your comments are right, and both comments are in the definition of recurrence. Thank you.
Thank you, Omar. You can complete your discussion later, but to reduce the incidence of recurrence, please try to use the new Fakhri classification for ablating varicose veins. It is just published in the Act of Robotica, May 2025. Now I would like to thank our dear Professor Chairman, Professor Hassan Lotfi, Professor Khaled Ataya, Professor Toli Raga, Professor Samir Ataya, and Professor Ayman Samir. Thank you. I enjoyed your company. Thank you, dear. And let us start our next session. And I will ask Professor Walid and Professor Toli to announce the opening ceremony. Please, guys.